Well, thank you, Dr. Molitaris. I think we've heard two very eloquent presentations, one on the whole field and the second on the workforce. And we're going to pick up on the team concept now and talk a bit about nursing. And our next speaker, Judith Woodruff, is a JD, not an MD or a PhD, and I think that's very important. She's bringing a different perspective to this. Judith directs the Northwest Health Foundation's Workforce Development Program. She's been responsible for facilitating effective partnerships with health workforce leaders, health professional organizations, community-based organizations, health systems, advocacy groups, government agencies, educational institutions. She's also been director of a very important national program director for Partners Investing in Nursing's Future, which has been a Robert Wood Johnson National Collaborative Initiative, and I think one of the most important programs that there has been in recent years. 50 projects in 37 states, including the Western Pacific Islands, have been funded since 2006, with 220 funding partners and 500 organizational partners. So that's very important. And Dr. Molitaris was talking about new partnerships. How do we bring people together? And everybody should benefit when we do that because there are nurses in research and can bring insights there. They can take messages into the community, or patient care technicians, different parts of the team. And I think another aspect of Judith, which is very important, in 2001, before she joined the Northwest Health Foundation, she was Assistant Attorney General with the Oregon Department of Justice, Charitable Activities Section, which regulate 12,000 nonprofits in the state. So she's concerned about equity and justice. How do we provide better patient care? And it's not going to be just one group of the nephrology team. And I really believe nephrology has to take the lead. I think we have an opportunity to do that, which is probably unique in the history of nephrology. And since I came from neurosurgery, that's easy for me to say. But I really think this is a tremendous opportunity because nephrology brings together so many different things. So without more ado, Judith, and Judith and I talk about changing the world. I think that's what we're all here to do. So, Judith.
Thank you. Don't be looking for slides. I never do slides. It's true. I'm not a nurse, and I'm not an expert in nephrology. So I sort of wondered when Barry asked me to speak today. But I'm here to talk to you a little bit about how the relationships between philanthropy, private philanthropy, public organizations, and nursing workforce development has achieved some great accomplishments in the last 5 years. First, a little bit of statistics, since you've been hearing quite a bit from the physicians about the missing nephrologists. We also have a lot of missing nurses in this equation as well. In the U.S., there's somewhere between a 380,000 shortage of nurses to 1 million, depending on who you ask and what day and where you're working. And originally there was an estimate of 1 million nurses would be needed by 2020. That's been decreased as a result of changes to the economy and a number of nurses who stayed in the workforce that were not anticipated and did not retire, but they will still retire at some point. Nursing schools are at a capacity. They're unable to increase enrollment due to a number of factors, in particular because they have an aging faculty. The average faculty age in the United States for nursing education is 55. The average age for a nurse is 47.5. And so we have a number of capacity issues within nursing education as it stands currently, much less if we wanted to add any nursing students to the equation. Specialty training is not provided in nursing school. It's provided on the job. And so nurses come out with a general nursing education capable of serving in many different roles, but specialty nursing is something that is considered practice-based education and is received depending on the unit in which you become employed. This is a real shortage, not just a cyclical shortage. We've had shortages of nursing in the past. This is 10 years and ongoing and has not decreased substantially in that 10-year window, despite a number of efforts to increase the production of nurses. As fast as we're producing them, we're losing them, either to other practice sites outside of care settings or to retirement or to other occupations. Another issue, again, as I said, is the aging nursing workforce, fewer faculty, and there's a decrease in the support for nursing education at state and federal level. The number of dollars that go into graduate medical education completely swallows and digests the amount of money that goes into nursing education, I can tell you. There's changes in the expectations of the new nursing workforce. Generation X, Y, and Z, which are now called the millennials, have different expectations of work in the practice setting as well. And then finally, there's a poor utilization of nursing skills. Nurses do things that they shouldn't be doing because they are the only ones available sometimes. And so the use and utilization of nurses in practice settings as a hunter and gatherer of supplies has been a significant factor in how nurses work in the environment and the amount of time that they have in patient care. I'm not going to talk to you specifically about nephrology nursing because frankly, I don't know anything about nephrology nursing. But I know that this shortage is specific to all critical, all specialty care, and that dialysis treatment and nephrology is no exception to that. Specifically, with regards to how that's being addressed, is nursing shortage in general has to be addressed before we can address any issues with regards to subspecialties. In 2008, the Robert Wood Johnson Foundation and the Institute of Medicine launched a 2-year initiative to address and respond to these issues and to transform the nursing profession. The IOM appointed a committee on the initiative on the future of nursing with the purpose of producing a report that would make recommendations for an action plan to address nursing. That's not to say that this hasn't been happening all along, but this was a pivotal event in the nursing profession. The committee considered nurses across roles, settings, and education levels in its effort to envision the future of nursing. And the committee's report, which was released last October, developed 8 recommendations to ensure that the nursing profession is capable of responding to the current crisis, but also to transform nursing into what it needs to be for the 21st century. There were 8 specific recommendations that support 4 key messages. Those 4 key messages are that nurses should practice to the full extent of their education and training. They should achieve higher levels of education and training through an improved education system that promotes seamless academic progression. Nurses should be full partners with physicians and other healthcare professionals in redesigning healthcare in the United States. And finally, that effective workforce planning and policy making require better data collection and an improved information infrastructure. These are really key important issues in terms of how we're going to move forward with the development of nursing for the 21st century. I won't go into the 8 recommendations, but they're certainly available at the IOM, through the IOM report and the initiative on the future of nursing. But hurry up and wait has often characterized healthcare workforce issues, and nursing issues in particular. How many times have professional, institutional, and public policymakers put these issues on the agenda only to have those efforts dissipate and produce only modest change? This has happened cyclically in nursing, and I assume that it probably has happened with physicians and with other healthcare workforce. At 3 million strong, that's how many nurses there are in this country, and the largest sector of the healthcare workforce, there's a lot at stake in how we address the issue and how we'll build and use the nursing profession in the future. Collaboration between local, regional, and national philanthropy, workforce development agencies, education, health systems, and nursing leaders is vital to creating an adequate nursing workforce for the 21st century. So what's happening to help make that to help make these changes? As Barry indicated, in 2005, the Partners Investing in Nursing's Future program was born, a partnership between a large national funder with a great deal of experience in nursing and a small regional local funder, Northwest Health Foundation. We're located in Portland, Oregon. We've been doing nursing workforce development in the state of Oregon for 10 years and have accomplished some significant changes both to education and to practice in that time period. Our program, Partners Investing in Nursing's Future, which is affectionately known as PIN, supports innovation and collaborative relationships between local and regional projects that address nursing issues. We leverage the interest and capacity of local foundations and other funding sources to make long-term investments in the development of the healthcare workforce and to establish a new model of partnership to ensure the success of the program goals. Key to this program is a relationship between a local funder, foundation, private philanthropy, with nursing workforce development, nursing academia, and nursing practice to develop pilot projects and solutions to the issues. This is a unique program because typically in philanthropy, there's a grantor, the philanthropist, and there's the grantee. And in this case, we work towards having a shared table and a shared partnership with regards to solving the crisis. As Barry mentioned, in the last 6 years, we've funded 50 partnerships in 37 states and the Western Pacific territories of the Marshall Islands, Guam, and Saipan. And this includes over 200 funders and over 500 partnerships, and that includes hospitals, health systems, economic development agencies, private industries, and even a couple of banks, which is a very interesting relationship to have with a bank trust department. Projects developed through PIN include maximizing the use of simulation technology in Florida, to fostering nurse leaders in West Virginia, to developing new nursing curriculum in Massachusetts, we have 3 projects in the state of Mississippi, one of which is supported by the Dreyfus Health Foundation, Global Health Foundation. The PIN projects are as diverse as the profession itself. None of the projects were introduced as a requirement. Each of the sites got to develop their own project and to fund it and support it as it addressed a local issue. Nursing is, while it's a large profession and is a national shortage, it is a local response and a regional response that needs to take place. As you heard earlier today, the changing demographics is going to impact this nursing profession in a way that the nursing profession in the last 50 years has not had to accommodate. Baby boomers aren't babies anymore. And the needs of this population cohort are complex and potentially devastating to our entire health system. For you here today, that means that an ever-increasing demand for the skills and talents of nurses that are skilled in dialysis and other nephrology treatment. For our program, this means we have consistently placed a very high priority on the funding of projects related to geriatrics nursing. In central Minnesota, that means training faculty to teach core competencies in the care of older adults. Most nurses graduate from nursing school without much information at all about the geriatric patient. Just like, as indicated by the previous speaker, about physicians coming out of medical school without any knowledge of nephrology. Nurses don't have any knowledge of geriatric patients. So we have to train the faculty in order to teach students. In Arkansas, our project is developing a career pathway to create more geriatrically trained nurses, from CNAs to LPNs to registered nurses to advanced practice nurses. We have to create educational pathways that allow for nurses to grow and continue their learning in a lifelong way and not simply get a terminal degree at an associate level or a baccalaureate level and then go into practice, never to return for more education. It's a critical piece of what we're trying to accomplish in the state of Arkansas. In Mississippi, the PIN project has developed 6 dedicated education units to train nurses in a variety of acute and long-term care settings, to train nurses with regards to geriatric education. For those of you who aren't familiar with the concept, dedicated education units started in Australia and New Zealand, and they are units that are devoted exclusively to the education of nurses and other professions in some cases. That means that all of the staff on those units is focused and understands the role that they play as an educator, and they train nurses with the idea that this has to be the very best experience they are ever going to have on this unit, in order, both in terms as an education tool, but also as a tool for recruitment and retention of nurses in those practice sites. It's been very successful on med-surg units around the country. It started in Portland, Oregon, and it has grown into an effort in many, many hospitals and education institutions to create these units. In Mississippi, they focused on long-term care and geriatric nursing, and one of the sites, they have 6 sites there, one of their sites is in a dialysis unit. And the hospital, which requested this, said that it was the hardest unit in the hospital to recruit and retain nurses to. It was consistently underrepresented. They had no nurses, they had shortages, they had people floating in who had no experience. It was consistently difficult to keep nurses on that unit. So they turned it into a dedicated education unit, which meant they brought people in to teach nursing students about the importance of it. They brought in patient advocates. They created a unit that is designed to not only train nurses how to perform the tasks, which are very important, but how to understand the role that they have in the future in such a unit as this and the growing field that they could be working in. These units, the way that they are built, consistently show students the real world view of what a patient's experience is, because they spend more time with the patients and they get nursing education and they get instruction on how to be a nurse from people who are passionate about the work that they do. It's very important when you're training new healthcare providers that the person teaching them actually believes in what it is that they're doing and is not simply there on the unit because they got floated there last week because somebody was out. So they're nurturing them into this specialty practice, and it's very important for specialties to have that viewpoint that you have to nurture people. You can't just expect them to show up because they won't. So in a year's time, I'm happy to say that that unit has gone from the most difficult placement to the most sought-after student placement in the hospital. And I can only say that it's partly because of the emphasis on teaching and nurturing, but it also might be that perhaps we've sparked some interest in nurses in renal disease in a way that wasn't there before, because of the passion of the nurses that are teaching on those units, and in a team approach where everybody on the unit, from the dietary worker to the physician, understands that this is a teaching unit. And that's very similar to perhaps the way nursing and medicine were taught years ago, but we're sort of returning to that again in terms of what we want to accomplish. The mentoring is provided by all the staff, not simply by the nurse educator, but all the staff that work with those nurses and with those others on those units. So why are projects in geriatric nursing so important to nephrology? Other than the DEU, I can tell you why. Because the fastest growing U.S. population is over 85 years old. Number one, fastest growing population. Because the prevalence of chronic kidney disease, as you heard, is almost 40% in people over the age of 70. Because the geriatric population is the most rapidly growing kidney failure population in the United States, I understand. And these are statistics I got off the web as a non-nephrologist and a non-expert in the field. I'm beginning to understand that this is an issue that is not just an issue of general population, but a serious issue for the geriatric population that's been separated somewhat from geriatrics, quite frankly. Because of the anatomical and physiological changes associated with aging, treatment for renal disease has to be different. It can't be the same as it is for younger population. Because the key to addressing the increasing demand for nephrology nurses and nurses who have skills in this area will be the development of all nurses to care for geriatric patients. Once all nurses are trained in issues relevant to aging, more nurses will have the skills that can be transferred to this specialty care. But we have to start somewhere with training all nurses to have the understanding of the geriatric patient. If that's going to be the bulk of your patients, that's where you should be training nurses. Every day, somewhere between 7,000 and 10,000 people are aging and becoming Social Security age 65. Some say 7,000, some say 10,000. That's a lot of people, frankly. We need all nurses to be ready to provide care to these older adults. With this rapidly growing population, we don't have the luxury anymore of creating subspecialties. We really don't. We need all nurses to be prepared because in some hospitals and in some communities, we don't have subspecialty units. We have general units. We have people who have to respond to everything that takes place. I live in a state that's predominantly rural. 3/4 of the state is rural, and about half of that is considered frontier. Frontier means there's, I think there's 6 people to every mile, something like that. So critical access hospitals that may have a need for these kinds of services cannot afford to have subspecialties. They have to have people that are trained to respond to all of the issues. And nephrology certainly sounds like, from what I've heard this morning, one of those ones where we need to expand the training for nurses all across the board so that they can understand the patients that they're seeing. We cannot continue to educate, train, and use a healthcare workforce in the same way that we have for the last 100 years. And this includes medicine. Interdisciplinary education that leads to team-based care where each member of the team has a role and a responsibility will be essential in the coming decades. We can't afford to have a physician give orders and have the rest of the team take those orders and implement them. It has to be done from a team-based approach that everybody has a role in this solution and everybody has a role in improved outcomes. People are going to be expecting that. We will not be able to create the number of new nephrologists that you'd like to have. It's just going to take so long to respond. And I think that probably we have to come up with new ways of creating a medical team that has the experience and the skills in order to respond to the needs that we have. We're not going to be able to create the number of nurses we have. Nursing education has to be transformed in this process so that we have nurses that are better qualified and prepared to lead the way and who have the information that they need in order to respond to the critical thinking that's required by nurses on these particular issues. Chronic disease is crippling the healthcare system, crippling it. If the number of children who are predicted to have diabetes in the future are allowed to actually get diabetes, we're in huge trouble, not just medically and not just in providing care, but our entire society could cripple as a result of the impact of diabetes on our healthcare system. We have to figure out new ways of delivering care. We have to figure out new ways of instructing and training and developing our workforce in order to respond to this. We will have to navigate among divergent forces. For example, the desire of professional associations and their members to increase scope of practice, compensation and standing among professionals versus the desire of employers to hold down labor costs and the desire of the medical profession to continue to practice in its current environment is going to be a challenge. We shouldn't kid ourselves that everyone is willing to join hands and sing Kumbaya and move forward with these changes. It's very difficult work. Collaboration amongst interdisciplinary work is extremely difficult, but it can be done. The transformation that's envisioned requires a culture change. Culture change in hospitals, in practice settings, and in educational programs. We have these challenges ahead of us. We can't just train nurses differently. We need parallel changes in the training of doctors and other health professions and in healthcare management, frankly. We have to see it as a system problem, not simply a workforce silo problem. We can't just train more doctors and more nurses and more CNAs and people and expect them all to work in the same environment and get the same thing done. It's not going to happen. It's that, description of insanity. You keep doing the same thing and expecting something different. It's not going to happen anymore. We have to look at it from the perspective of someone like myself who's an outsider that says, that's not working. We need to come up with a new approach. We have an incredible convergence of powerful forces right now. Health reform and the conditions that it creates, the challenges for payment reform and for other issues, the aging population, the aging of the workforce. One of the issues that I think maybe perhaps wasn't addressed this morning is the aging of the nephrology physicians. That's an issue, just as it is for nursing. The aging of the people that you have, how quickly can you replace them? A real nursing shortage as opposed to a transitory one. This is a permanent condition. The shortage of nurses is a chronic shortage. It is not going to go away, so we have to think differently. But there is an increased interest in nursing education and practice, in advancing the role of nurses in different settings, creating advanced practice nurses, creating advanced clinical nurses who can provide additional skills, perhaps in a shorter time frame than a nephrologist can. Even without the Accountable Care Act and the federal health reform, increases in the demands for services because of the aging of the population, the increased prevalence of all kinds of chronic diseases, innovation and treatment, and the imposing role of healthcare technology and in the disparities of care for certain populations underscore the inefficiencies and inequities within our current system. There was a description of the end-stage renal disease patient who comes in 15 different chronic diseases and is over 75. That is the current population in the hospitals these days. It's not just end-stage renal disease. The chronic patient that is in and out of the hospital all the time because of poor chronic disease management in the community settings. That's what we're dealing with. We're not dealing with the patient who was a healthy 35-year-old before they had an accident and came in the hospital for treatment and got to spend a week there. Leveling the Accountable Care Act demands on a dysfunctional system reinforces the need that we need to change the way that care is delivered. And without that, the nursing shortage is really just a symptom of the overall problem. There's widespread understanding now that expanded coverage is not a guarantee to access if you don't have an adequate workforce. We will not be able to meet the needs of our population without the creation of a new kind of workforce for the 21st century. This context should provide a new imperative to look at the longstanding issues in the training and deploying of nurses in different ways to finally take some of the actions that have been on the agenda for a long time but have yet to be achieved. Thank you.
The challenges are tremendous. We're going to take, and I think Judith brought that into tremendous focus. We're going to take a short break now, but after the break, we're going to move into how we take some of the issues we're dealing with into the community and begin to change, break down the walls that surround our clinics and take these things out. And we'll hear the last two talks right after the break. So about 10 minutes and we'll regroup here.